This conference will now be recorded.
At this time, I'd like to introduce you to our speaker, Carla Wilbur, Senior Consultant at Stroudwater Associates. Carla Brock-Wilbur is a registered nurse, seasoned clinician, as well as an accomplished nurse administrator with a background in critical care, education, and emergency services. Carla was Director of Enterprise Excellence at Wake Forest Baptist Health Lexington Medical Center. She led their Lean Transformation Initiative and was responsible for the comprehensive performance improvement and lean redesign initiatives. Carla earned her Doctorate of Nursing Practice from George Washington University and holds a Master of Science in Nursing Leadership from East Carolina University. She obtained a Bachelor's in Nursing from Winston-Salem State University and is now a Senior Consultant with Stroudwater Associates. Now I'll turn it over to you, Carla.
Thank you, Kim. I want to make sure that everyone can hear me well.
If you have any trouble hearing at any time, you can just send us a note in the chat box.
Thank you. All right, so again, this is Improving Care Transition and HCAP scores. Yesterday we had part 1, and today we will go over part 2. We discussed the HCAP survey yesterday and the questions associated with Composite 7. We defined and discussed the transition of care. And today we'll do a bit of a review, but then evaluate best practice actions for improving care transitions. So, and we saw this slide yesterday, but I have added it again. It's just really important to understand that throughout our nation, and on the left-hand side, and I hope you can see it better once you download your slides, the left-hand side has all of the states listed, and then in the center, in the red, I have the care transition scores. As you can see at the bottom of this slide, in the United States, we are only, our average top box score for those that are publicly reporting, we're only at 52% for Composite 7, which is care transition. So Composite 7, just as a review, includes 3 questions, questions 23, 24, and 25 on our HCAP survey. The first question within the composite is the hospital staff took my preferences and those of my family or caregiver into account in deciding what my healthcare needs would be when I left the hospital. In that particular question, of course, we believe the key word there is preferences. And as we discussed in part 1, preference is defined as a feeling of liking or wanting one person or thing more than another person or thing. And knowing a patient's preference is monumental to their experience and often impacts the outcomes. We also discussed our responsibility to cultural sensitivity as well as tailoring their care while there and customizing care to improve their journey. The second question within that composite, when I left the hospital, I had a good understanding of the things I was responsible for in managing my health. The key words in this question are understanding and responsible. In part 1, we discussed how disruptive hospitalization is for our patients and that the environment of increased anxiety and stress does not promote the asking of meaningful questions at times by our patients and or caregivers. We also clarified that partnership implies that we want clarity surrounding the expectations and responsibility that we all have in improving the health of our patients. The third question within this composite, when I left the hospital, I clearly understood the purpose for taking my medication. Keyword, clearly understood. We also reviewed a vignette that the Joint Commission had published where we saw an example of an unfortunate readmission outcome reflecting a health literacy concern where a 68-year-old man did not take his medications because he could not read. From Part 1, we know care transition is vitally important to overall patient outcomes. So let's examine which transition within the patient journey, which is all movement, handoff between settings and practitioners, is considered the most critical. The next few slides contain information from a recent study done by Healthcare Intelligence Network. Responses to the study were submitted by 116 organizations. 35% of those organizations identified themselves as hospitals. When asked which care transition is most critical, 43.5% of these hospitals answered hospital to home, followed by hospital to post-acute. It makes sense for hospital to home to be most critical given the impact a lacking support system might have, influence of socioeconomic factors, health literacy concerns, transportation difficulties, and the list goes on. Within the same survey, 84.6% of hospitals responded they have a care transition management program. However, it was unclear whether this is a focused program on one chronic disease or more than one chronic diseases. Many facilities have chronic condition-specific programs, but unfrequently do we see facilities with a full care transition program. There are currently numerous care transition programs being used in hospitals across the country. Some of these are Coleman's Care Transition Intervention Model, Guided Care, Transition Care Model, Add Life, Project Boost, Project Red, CMS community-based programs, STAR, and many other hybrid models, some of which are being designed at the hospital level. So these are polling questions. Of the facilities on today, how many of you have a care transition program that focuses on more than 1 to 2 conditions? Okay, so it looks like, it's still changing. Okay, so it looks like there are 41.6, so out of, so it'd be 5. So 5 facilities, 6 facilities do, no, 7. I'm not being very patient. So that's kind of 50-50. 7 focus on more than 1 to 2 conditions and 7 don't. Okay. The next polling question, of the facilities with programs, which conditions are targeted by your program? So Kim, is that, are we able to see that, or is it not?
Yes, I'm seeing right now we have CHF, COPD. COPD is mentioned twice. DM, CHF, asthma. Are you able to see that there on the second poll?
I can't see that. Okay, I do now see CHF and COPD. Okay. All right, great, thanks. The survey respondents in this particular study shared that heart failure was 87% of the time. COPD was targeted 78.3% of the time, and pneumonia targeted at 69.6% of the time. So in the next polling question, of the facilities on today, Which risk factors do you believe qualify patients for a care transition program? So we have 6 answers. comorbidities, age, home environment, frequent readmissions, socioeconomic status, age, complexity of medical problems, availability of caregiver support, environmental, lack of insurance, rural status. Those are pretty common. When the participating hospitals of this particular study were asked the question, what were the risk factors qualifying patients for care transition programs, hospitalization was chosen as 90.9, followed by comorbidities at 77.3, and frequent ER use at 68.2. Many transition programs use a variety of tools to help manage their care transition. Some of those tools are discharge templates, handoff forms, teach-back tools, handoff checklists, handoff protocols, handoff training, recorded instructions, and medication reconciliation. Of the facilities on today, what transition tools do you think are more effective?
Can you give some examples of transition tools?
Yeah, that's what I had just said, the transition tools of discharge templates, handoff forms, teach-back tools, handoff checklists, protocols, handoff training, medication reconciliation, or recorded instructions. So we have one, okay, good. Education on meds and disease conditions, that's a great answer. And tools that are based on best practice. Utilizing teach-back. Good, MedRec and discharge templates. Okay. Oops. All right, I'm trying to move to the next slide. So 72.7% of the survey respondents in this HIN survey responded MedRec is a tool used to manage transition. As we know, millions people are harmed each year due to medication errors and cost the nation billions of dollars. With 60% of medication errors occurring during a time of transition, it's imperative that an accurate and thorough medication reconciliation process be in place. In addition, patients 65 and older with 2 or more chronic conditions see up to 7 different physicians. This alone creates room for inefficient and ineffective care transition and med errors. So what other options should we use for transitioning to other sites? There are numerous options available in transitioning to other sites. Telephonic follow-up has been noted at 77.3%. And on November the 3rd, CMS published new revisions to requirements for discharge planning. That's a huge step in the right direction for improving our care transition. But as we know, even the best discharge plan doesn't always work if the patient is not totally engaged at the time of discharge. So a hospital I recently worked with has implemented follow-up calls the day after discharge with the specific purpose of reviewing the entire discharge plan the day after discharge. This has worked very well for them. Community linkage is also an area we seem not to use very often. At my former facility, we had a program sponsored by the hospital called Faith Health. This program involved multiple churches and lay volunteers to partner with patients to help them with transportation, picking up medications, and many other needs that otherwise would have been unmet. Timely PCP follow-up